Great, welcome. Thanks a lot, Paul. So, there's a lot, obviously, in terms of what are needs, and I'm sure everyone has a different perspective. And I think this is an interesting session where I think there's a lot of areas where we can have discussions, and I don't think all of us will agree as to what's required and what's needed as we go forward. But, over the last decade, TAVR sort of evolved from a niche procedure to an integral part of the treatment algorithm for aortic stenosis. It's now the preferred therapy in intermediate risk patients. And if you just look at the recent TVT and STS database, and although the STS includes the vast majority, but this year there's more entries in the TVT database than STS for AVR. So it's really fundamentally changed the dynamic of how we treat these patients. Ongoing trials in lower risk patients will address the potential expanded role of TAVR and also provide some data in regards to durability. But there's a lot of data still lacking in important subsets of patients. And we'll hear from Danny about valve, and we'll hear from others about different points. And I think there's a lot that we need. And one of the first ones is ongoing data collection in important subsets of patients that were excluded from these randomized controlled trials. And, there's a few to discuss, and ones that comes up often is bicuspid valves. And I think a lot of us are treating. We've also learned through this process of imaging that all bicuspid valves aren't the same. What we consider sort of the type 0 is a small percentage, but there's a lot of type 1 bicuspids out there, especially in these older patients. Does valve type matter? Are the procedural results comparable to tricuspid? And when, there's been some registries published, this one last year in JACC, looking at first versus second generation versus third generation devices, there are different complications with bicuspid valves, pacemaker rates, valve embolization, especially PVL. And I think that's an important thing. And different devices potentially have some advantages over others, but we don't know that data well enough yet. And also, even if you get an acutely good procedural result, if you have asymmetry at the valve, will that impact durability? We know in surgical valves it does, when even just the way they manufacture. So this asymmetric valve, I think there's significance of potentially impacting durability. And one of the challenges here, unfortunately in the low-risk trials, bicuspid valves were excluded. The Lotus in Reprise is going to have a bicuspid registry, so we'll get some good core lab data, but we need rigorous data about this. And the other big question is coronary disease. As we're treating younger patients, we're seeing a lot of patients with mixed coronary and valvular disease. So is TAVR PCI, CABG AVR? How do we assess the potential risk to the patient? We have multiple series been published. This is one of the first in the European Heart Journal in 2014, looking at the impact of CAD on outcomes. And severity of coronary disease didn't really impact 30-day outcomes in this series, but when you look at longer-term outcomes, and by longer-term, just a year, patients with severe coronary disease with the syntax score over 22 had a higher cardiovascular death, stroke, or MI at 1 year. This was a recently published, again, this was a couple years ago, looking at low-flow, low-gradient patients. So that challenging subset of patients, when you look at that group of patients, incomplete revascularization led to higher cardiovascular mortality. Overall mortality was higher. It didn't reach significance. I think it's just a numbers issue. But incomplete revascularization leads to higher mortality and is associated with worse outcomes. This was a study just published a couple months ago. It's from a series of centers in Israel. Again, showing the same thing. Severe coronary disease, syntax score over 22, and incomplete revascularization with the residual syntax over 8 were predictors of increased mortality on multivariate analysis. So although it doesn't impact the 30-day results in most of these series, there's growing evidence that it impacts late mortality. We looked at our own series along with Dr. Rodez Cabot in Canada. We didn't see the same, but again, it might be a numbers issue, and these aren't randomized trials, these are registries, and so it's challenging. And so when you look at coronary disease, there's no uniform treatment algorithm. We all do things differently. There's no randomized trial data that tells us how we should treat these patients. And we treat patients differently. In a 90-year-old, we may not stent the LAD, but in a 75-year-old, we do. Is that the right answer? We don't know. And we need large, rigorous data sets. Ideally, it'd be randomized controlled trials. I'm not sure we're going to get that, but that would be ideal to answer the question. And so, beyond these data sets, we need comparisons across valve types. I think we're excited about TAVR, but each TAVR device interacts with the aortic valve complex differently, and that interaction can change important complication rates. such as stroke, such as PVL, such as pacemaker rate, such as durability, asymmetry, and these may be different across different valve types. The Reprise trial gave us the first comparison across 2 different THVs in a randomized trial. And there were differences. When you looked at the combined endpoint, including PVL, Lotus was superior to CoreValve. Is that important? What does that mean in the grand scheme if we're looking at long-term outcomes? And we'll need more data across these devices, including longer-term data, because the durability of each of these devices may be different. And we've seen that in the surgical valves. I mean, there were several surgical valves that are no longer used because at 5 and 7 years, their durability was less than some other surgical valves. And I expected durability is going to be different, but we need to be able to characterize that and understand the differences. And obviously, there are 2 leaders in the U.S. We'll have a third valve approved within a year, and there are others that are going to be doing trials in the U.S. And, the ideal valve has a lot of characteristics that we'd all like. Minimal interference, simple deployment, low complication rates, low profile, and durable. However, there's no ideal valve for every anatomy, and trying to decide which valve is best for each patient is the challenge. And this is very different from the surgical model, where any valve I think you can sew into any patient. But there may be differences based on patient anatomy across different valve types, and I think that's the ones that we're trying to figure out. But there are other challenges about valve type as well. If you're doing only 25 a year, you can't be an expert in multiple valve types. Anatomic factors will play a role, such as LVOT, calcium, low left main, effaced sinuses. Coronary disease and potentially access to the coronaries later may impact your decision. And the indications with valve and valve versus bicuspid. But this is all stuff that we're doing empirically without data, and we need a lot more data in regards to this. So in a patient with heavy calcium, we may choose self-expanding. In a patient with depressed LV function and narrow QRS, you might want to avoid pacemaker risk and do balloon expandable. But these are choices that we're making. And we need the heart team role to evolve. I mean, the heart team was established to provide optimal care for the patient, independent of the physician bias from preoperative assessment to procedural care. But in the beginning, it was about risk assessment only. It was about, okay, this patient is not a good surgical candidate, let's do TAVR. But as we get to lower risk patients, and there are a lot of people that are involved in the heart team, but as we get to patients where it's truly an option, we need to consider the patient in that decision. And that's not integrated really into the heart team model right now. And what's right for any individual patient may not be right for the next. And the patient preferences and values must be considered. And now the heart team really needs to have an honest discussion of the risks and benefits of the different treatment options. And it's really not about whether to treat or not as it was in the early days of TAVR. It's, okay, this patient needs 3 stents and TAVR. Are they better off getting a CABG AVR? If they have proximal vessel disease that's prognostically significant, that may be better served by CABG. That's the decision that needs to be made. And who should provide the information? And really trying to provide it, cardiac surgeon, interventional cardiologist, the cardiologist, some uninvolved person. And we need to get away from these arbitrary requirements, such as 2 surgeons need to see every patient. A 90-year-old functional person that had a prior CABG shouldn't need 2 surgeon assessment. And we need to, as physicians and societies, try and advocate. And I know there'll be new documents coming in. And as I said, patient preferences need to be considered. The other thing is the heart team has to integrate the echo and CT results. If someone has ideal anatomy for TAVR, even if their STS is 3, they may be better off. But someone has not ideal anatomy and you're pushing the limits and their STS is 6, they may be better off with CABG AVR. So the decision should be integrated with the imaging as we go forward. And then obviously procedure planning and need for revascularization and valve choice. That's really where the heart team is going to come in to a much larger thing. And the last area that I really think that we need a lot of data is areas where now TAVR can expand the population beyond where surgery has gone. Surgery works well, but we haven't done surgery in asymptomatic patients, in moderate AS patients, and TAVR may have advantages in those settings because it's less invasive, less peri-procedural mortality and comorbidity. It's better tolerated in instability. It's an easier recovery. TAVR may be a treatment option in patients where surgery is not. So we shouldn't limit TAVR to just what is the surgical indication. And there are 2 trials that are ongoing that will maybe allow TAVR to expand its indication beyond the traditional surgical one. The first is in patients with heart failure and moderate AS. Heart failure is characterized by increased afterload, and our treatment right now is medical treatment to decrease afterload. Aortic stenosis is also characterized by increased afterload, but basically at the valve itself. And so, one of the concepts is in someone with moderate AS and cardiomyopathy, unloading the ventricle by fixing the moderate AS, and you can get rid of that valvular load. You'll decrease their overall afterload, and they may have improved clinical outcomes. And there's a randomized trial ongoing now comparing TAVR versus optimal medical therapy in patients with moderate AS and cardiomyopathy. And this is something that surgery won't get to because it's a more invasive procedure. And then asymptomatic patients, there's a recent meta-analysis that showed there's an increase in mortality with medical therapy. And there's a trial ongoing now suggesting that in patients that are asymptomatic, perhaps treatment early may have benefit. So this is a randomized trial in asymptomatic patients, TAVR versus continued medical care, and looking at long-term outcomes. And this trial has already started enrollment at this point. So there's a lot of opportunities, but we basically need to collect more data and continue to move the field forward. Thank you very much.